I find bipolar disorder, the change of bipolar disorder diagnosis over years to be really fascinating. In 1974, the first step was this awareness that if you can pull out the people who have bipolar disorder from a group that you thought had schizophrenia or schizoaffective disorder, then you could potentially put them on something else other than an antipsychotic, like lithium, like an anticonvulsant. And then that group, when treated properly and when diagnosed properly, would have a better long-term outcome. So to me, the first step in the changing of the bipolar disorder diagnosis was pulling a number of people out of the schizophrenia subtype so that they could get better treatment. The mid-1980s was another change, and I think a lot of this is due to the work of a Kiskell, who felt that, oh, wait a minute, bipolar disorder isn't just bipolar disorder. It's actually a spectrum of mood regulation problems that are subclinical but just as meaningful and very closely related in terms of family studies, in terms of the kinds of treatment you give. And so a Kiskell started pulling more and more other related mood regulation disorders into this. So you would have your bipolar disorder 1, which would involve mania and depression. You'd have your bipolar disorder 2, which would often involve severe depression and hypomania. Then you would have a bipolar 3 or cyclothymia, which involves fairly large changes in mood over time. At the beginning, there was also a thought that people who have episodic, irritability or anger outbursts should also be part of this, as well as some other related disorders. So the outcome of that is bipolar started getting bigger and bigger and bigger. And part of the goal was, one of the reasons it got bigger is this feeling that if you give somebody with one of these sub-threshold or like not evident forms of bipolar disorder an antidepressant, they could switch into a manic episode, and that would be dangerous. And that, so in other words, you could kindle or create a disorder that otherwise would have remained sub-threshold. So there was a lot of interest in finding who are the people with bipolar disorder who have something, maybe they have bipolar disorder in their family, or maybe they have hypomania that looks just very productive but is not but is really a form of mania. So can we pull those people out and then treat them in bipolar? But of course, once again, bipolar got larger then. And then in the 1990s, we began to have the additional interest in pediatric bipolar disorder, and I'll talk about that in a second. And the belief there was that there is a variant of, or prodromal form of bipolar disorder that begins among kids, and if you can catch it early, you can treat it early and avoid what's called this kindling effect, which is another metaphor, by the way, that began in the 80s and 90s. The belief was if you treat something with medication early on and you treat it with family intervention and with behavior therapy, then you can avoid the possibility that it's going to be kindled or recur many times through life. This concept of kindling started with studies of epilepsy, but now it really extends to treatment of depression as well as bipolar disorder. Okay, 1990s, another trend was increased use of second-generation antipsychotics for bipolar disorder, which I find also interesting because part of what happened in the 1970s was saying, oh, there are a number of people with bipolar disorder who don't have schizophrenia who shouldn't be treated with antipsychotics. So here, 30 years later, we're now saying that antipsychotics might be the treatment of choice for that group. The main thing happening now that you're going to see in DSM-5 is the narrowing the gate on pediatric bipolar disorder, and I know many of you have seen lots of publicity about this. So just a quick comment. Here's the bipolar disorder diagnoses. Bipolar 1, there's no change. Bipolar 2 is going to be pretty much the same. Bipolar 3 is a new name for cyclothymia, which is somebody who has hypomania and dysthymia, but not major depressive disorder and not a full-blown mania. but let's talk about pediatric bipolar disorder. So the concerns have been that through the 90s and the last 15 years, there's been increasing diagnosis of pediatric bipolar disorder. There's overdiagnosis, possibly wrong medication interventions, and inaccurate long-term prediction of who is actually going to get bipolar disorder in adulthood, and some awareness that this is a very heterogeneous disorder. Now, one thing we do know is it appears that about 40% of major depressive disorder among kids becomes bipolar disorder in adulthood. And because of this, there really was an interest in figuring out whether there was a childhood variant of bipolar disorder that could be treated early and properly. Then everyone started to try to understand, well, what is this thing we call childhood bipolar disorder? Does it look the same as it looks in adults? And it appears like it doesn't. You know, you have, it seems like there may be two subtypes. You'll have a narrow form, like kids who have hyperactivity and irritability, they have psychotic symptoms, they're grandiose, they have elevated mood, rapid speech, they don't need sleep. So that small group seems to have what looks like a child version of adult mania. But then there seems to be a larger second group. That's a group that's been getting the pediatric bipolar disorder diagnosis as well, but it looks more like, well, it does have this kind of episodic dyscontrol, but it's not cyclical. It may be continuous. These are kids who they get into a state and they can't get out of it, and they're not doing it to manipulate the people around them. They get rage attacks. They get rage attacks. They get out of control. They're irritable, and those kids were called, pediatric bipolar disorder. But the question was, well, it doesn't really look like mania, so people thought, well, maybe it's a childhood form of mania. The other way to think about it is, if it doesn't look like mania, maybe it really isn't mania. So the major change that's happening here is some subgroup of kids who would previously have bipolar disorder diagnosis are now their diagnosis is now moving to the depression spectrum, and it's called disruptive mood dysregulation disorder. So let me just go over this. So you have a narrow definition that looks like adult bipolar disorder. Those kids will still have bipolar disorder diagnosis. Then you'll have a different form that looks like explosive emotional outbursts. They don't look like mania. You don't have grandiosity. You don't have delusions. And it's not so cyclical. And it looks a little like ADHD, but there may be more aggression in the outbursts. And it looks a little like a disruptive behavior disorder, but there's a much greater affective component of it. This subgroup is believed to not be likely to grow up to have bipolar disorder. They're going to grow up and they're going to have anxiety or depression or neither of those. But they are not. That is not believed any longer to be prodromal for adult bipolar disorder. And I think the second thought is that a lot of them will not be treated using the same medications. So they're not going to get lithium. They're not going to get second-generation antipsychotics. They're not going to get anticonvulsants. Instead, they're going to be treated with antidepressants and Ritalin. I mean, the truth is that if kids are out of control, I'm sure that they're going to continue to get second-generation antipsychotics. But at least the movement here is to pull out some number of kids and get them into the depression category. So that's going to be called disruptive mood dysregulation disorder, and Rhoda's going to talk about that as part of the depression spectrum in a moment.
One of the difficulties, though, I think about that disorder as a clinician is I'm often seeing kids who might meet this description, but they're in the context of a family that's having difficulty, with parents who don't know how to set boundaries, who are very inconsistent in what they punish or reinforce, and teasing out what's the child and what's the family context can be very, very difficult.